Good evening, everyone, and welcome to today's wonderful evening with Dr. Murli Bharadwaj. I'm sorry I got late, carried away in the afternoon. So let's discuss AIMS past 22 years. And we already finished guide apps. We are in the midway of general medicine. And can the online students can punch? Is the voice loud and clear for all of you, doctor? Can you please punch? I'm broadcasting from home. That's the reason I'm always skeptic. Can you please punch whether you can listen the audio clearly? So now, doctor, neurology is one of the hot part of out of 30 MCQs in INICET. You will end up. Thank you, Ganesh, Alladi Vinay, and many more who are all online. At least 6 to 7 MCQs come from neurology. So you should know what are the priority topics for the neurology. The most hot topic from which invariably one MCQ comes in all the exams is stroke, cerebrovascular accident, which is not a usual feature of the right middle cerebral artery territory infarct, doctor. Generally, in the right-sided individuals, left is the dominant hemisphere. Unless left MCA stroke is there, aphasia doesn't come. Aphasia will only come in a right-sided individual only when the left MCA stroke is there. That's the reason aphasia won't be there. But hemiparesis, facial weakness, dysarthria, everything will be there. So what you are seeing here is a left MCA syndrome. Right hemiparesis, right hemisensory loss, right visual field cut. And the gaze will be towards the side of the infarct. So suppose if left middle cerebral artery is occluded, the patient will be looking, the gaze will be towards the side where the MCA stroke is there, is what you need to remember. In the right MCA stroke, as what you can see here, there is a left hemi-neglect, visuospatial hemi-neglect. The patient doesn't know that he is wearing clothes onto his left side of the body. There will be left hemiparesis, left hemisensory loss, left visual field defects. And a very important feature of a non-dominant hemispheric stroke is anosognosia. He has deficits, but he doesn't know that he has those deficits, which is called neglect of deficits. Anosognosia is a feature of non-dominant hemisphere, that is the right MCA syndrome in the people who are right-handed, is what you have to remember. Very good to see Meghaswana and many more who are all online. Yes. The commonest site for the hypertensive intracerebral bleed is, see, so many times. November 2002, May 2003, November, all exams. This was a favorite question. So you should not do a mistake. It is the putamen. So it is the putamen most common site for the hypertensive bleeds is what you need to emphatically remember for the tomorrow's exam. So the most common site of hypertensive hemorrhage is basal ganglia, putamen, thalamus, adjacent deep white matter. Most common intracranial hemorrhage is intracerebral or intraparenchymal. What are other types? There is a subarachnoid hemorrhage. There is an extradural hemorrhage, subdural hemorrhage. They are all less common. What is more common? Intracranial is a intracerebral hemorrhage. And the most common cause of the intracerebral hemorrhage is hypertension because of the rupture of the small penetrating arteries. And what is the most common cause of the subarachnoid hemorrhage, doctor? Trauma. because of the rupture of the berry aneurysm is what you need to remember. Good to see 13 online classmates. Can you please punch? Voice is loud and clear for all of you, doctor. Is the broadcast smooth? So, a hypertensive individual has a sudden headache, became unconscious within few minutes. There was a complete flaccid hemiplegia, no involvement of the upper face, right? And absence of tendon reflexes, positive Babinski. Which artery might have ruptured? So once more, it is the middle cerebral artery's lateral striate branch is the one which is affected. So you should remember, different parts, whenever there is any bleeding, how does it present? There can be a bleeding into basal ganglia, thalamic infarct, pontine hemorrhage, cerebellar hemorrhage. Whenever cerebellar hemorrhage is there, severe occipital pain. Oh my God, somebody is hitting from my back of the head. That's a presentation. Headache is very severe if it is pons or basal ganglia. Whereas thalamic bleeds, it is moderate headache. Pupils are normal in basal ganglia and cerebellum, but pinpoint pupils, that is small reactive pupils are the feature of the pontine bleeding is what you need to remember. Thank you, Megaswena Ganesh, for the feedback. Right? So, yeah. So now, doctor, if you look at the eye movements, how will be the eyes in a thalamic bleed? There will be hyperconvergence, absent vertical gaze. If it is thalamic bleed, what will you find in thalamic bleed? So basically, the two eyes will come into hyperconvergence. This is the nose. Hyperconvergence, absent vertical gaze is the feature of thalamic bleed is what you need to remember. Whereas pontine bleed, all your peripontine reticular formation controls your horizontal gaze. That's the reason horizontal gaze paresis. Horizontal gaze paresis is the feature of pontine bleed. Similarly, if you look at the sensory motor neuron lesions, doctor, if it is basal ganglia, then there is a hemiparesis. Whereas cerebellum lead to ataxia. Pons is the center for efferentiation. All efferents, motor output will go through pons. That's the reason any pontine bleed will lead to quadriplegia, is what you need to remember. Upper limb, hata pawa, kuch bhi utna nahi pate hai, Dr. Saab. That is quadriplegia, is a feature of pontine bleed. Thalamus lead to hemisensory loss, entire half of the body, including head. More than the motor loss, sensory loss is more with thalamic bleed. So all these things they will ask, doctor, tomorrow as the clinical Binet-based questions they will be asking. You need to be 100% sure when you go to the exam. Good to see Mithuna, Vinisha, and many more who are all online. Thanks for joining the session. This will be a brief session for 1 hour because I'm delivering this from the home. Generally, when students sit in the class, a lot of fun. to teach. 3 घंटे 4 घंटे पढ़ाई देने में भी मजा आता है. घर में अकेले बैठ के लैपटॉप को देखते हुए पढ़ाना बोले तो बहुत मुश्किल होता है. फिर भी आप सब मुझे दिख रहे हो. Alladi Vinay, Meghaswana, Ganesh, and everybody. That's the reason at least 1 hour I will deliver. Tomorrow I will take a very long class. Mithuna and everybody will come tomorrow. So, doctor, cerebellar lesions typically rise intracranial tension because cerebellum is in the posterior fossa in a very closed, compact area. Any bleed there will lead to raised ICT. So, early vomiting. And remember, pontine bleed may patient will be in a deep coma. He can't move his limbs. And pontine reticular formation is there, no? That will control our wakefulness. That's the reason there will be deep coma. Thalamus में सोते रहता. Hypersomnolence is the feature. And whenever basal ganglia are involved, then there is a development of conduction aphasia. So these points, please don't forget, doctor. Favorite question tomorrow, clinical vignettes में. Severe headache, normal pupils, normal eye movement, hemiparesis, conduction aphasia, basal ganglia. Moderate headache, small, poorly reactive to light pupils, hyperconvergence, absent vertical gaze, hemisensory loss more than motor loss, hypersomnolence, thalamic bleed. Severe headache, small reactive pinpoint pupils, horizontal gaze paresis is there, quadriplegia is there because of pons is a center for differentiation, and coma, pontine bleed. Severe occipital headache, but pupils normal, eye movements normal, ataxia, early vomiting, cerebellar hemorrhage. One of this will come like a clinical vignette in the tomorrow's exam is what you need to remember. Now, subdural hematoma most commonly results from, all of you know, venous bleed is subdural, arterial bleed is extradural, venous bleed is subdural. So elderly person, no history of trauma. Grandson came from America, just jerked, hey grandpa, and that led to the cortical bridging veins to rupture and led to the development of subdural hematoma. Subdural hematoma will be typically crescentic shaped. Every NEET PG ले लो, नहीं तो INICET ले लो, एक क्वेश्चन आएगा cerebrovascular accident. Entrance is not for 200, doctor. It is only 199, one question on CDA. In the last 5 to 6 days before exam, no, all these very high yield topics को एक मर्तबा मिक्सी में घुमा के जाना exam को. So the most common cause of extradural hemorrhage is the rupture of middle meningeal artery. This one. This is biconvex disc is extradural hemorrhage. Whereas this is subdural. This is subdural. This is venous bleed. Whereas this is extradural. Biconvex disc-like, which is extradural hemorrhage, which is arterial. There is a lucid interval, is what you have to remember. So this is how typically a extradural bleed outside the dura because of the rupture of the middle meningeal artery typically looks like, is what you need to remember. Very good. Meghaswana, Ganesh, everybody. Be proactive, doctor. Online class में क्या होता है ना, टीचर आपके सामने नहीं रहता. तो इसलिए unless you are actively talking, discussing, posting your points into the chat window, then it will be very interesting. Chat window is like your speaking mic. Talk, be proactive. So the only thrombolytic approved for the treatment of acute ischemic stroke out of all this is tissue plasminogen activator. Remaining things are given in the case of the myocardial infarction में सब कुछ देते, मगर दिमाग में stroke होता ना, वहाँ acute ischemic only, not hemorrhagic. You give tissue plasminogen activator. So this is alta place day in and day out in neurologists. So it is the magician In the first 3 hours after the onset of symptoms, if you happen to administer alteplase, there is a dramatic relief. It is the savior in case of ischemic stroke. Ischemic cerebral stroke is what you need to remember. So typically, if you look, it lyses the blood clots, that is clot buster, like blockbuster, clot buster, ischemic strokes. So whom do you give? You need to do CT scan confirming that there is no head bleed. Which CT? Non-contrast CT you need to do is the first investigation whenever a patient of stroke comes to you. And onset of symptoms within 180 minutes. Within 3 hours is the golden time. If the systolic BP more than 185, diastolic BP more than 110, CT head is showing any bleed, any head trauma or CVA less than 3 months, current anticoagulation therapy, any active internal bleeding, if the platelet count is less than 1 lakh, if the PT is more than 15, if the glucose is less than 50, if the glucose is more than 400, any of them contraindications for the tissue plasminogen activator is what you need to remember. So, doctor, very good to see Kallesh and many more. Keep punching your answers, doctor. That is how you will charge the session, right? Now, how much TPA will you give, Dr. Italia? 0.9 mg per kg, maximum 90 milligram IV as 10% of total dose by bolus, followed by remainder dose over 1 hour. If there is any decline in neurological status or if there is an uncontrolled BP, stop the infusion and give cryoprecipitate and re-image the brain immediately. Avoid urethral catheterization because it leads to bleeding is what you need to remember. And no other antithrombotic should be given for 24 hours is what you need to remember. So, doctor, 62-year-old diabetic female presented with history of progressive right-sided weakness of 1 month duration. We're also having speech difficulty. Fundus shows papillary edema. 2 months ago, she had a fall in the bathroom and stuck her head against wall. 2 months ago. So what is the most possibility? It is a chronic subdural hematoma, elderly person who developed venous bleed, presenting as speech difficulty, progressive right-sided weakness. So that is the typical story. Sometimes even this much of trauma history won't be there. So there is a crescentic bleed is what you need to remember in this given case. So best method for you to monitor the intracranial pressure kya hota hai? Best method. Intracranial monitoring. So you can see here, it is the catheter that you pass epidurally will help you to identify the intracranial pressure and can know when to drive a burr hole if it is epidural hematoma, as what you can see here. So this is how you drive a burr hole and typically drain the epidural hematoma. Beaver sign, where do you see? We see it in abdominal muscle. So typically you will look whether umbilicus is moving up or moving down. So movement of the umbilicals towards the head on flexing the neck is caused by, if it is moving towards the upper part, when flexing the neck is caused by the weakness of the lower abdominal muscles is what you need to remember. So typically Beaver sign is between T10 and T12 levels whenever there is any spinal cord injury is what you need to remember. So Alladi Vinay is saying, what is the door to needle time? Very good. So on arrival of the patient to the point where you have done a catheterization, right, where you need to poke the needle, and instill generally within 30 minutes, but golden hour is 3 hours. Within 3 hours, you can still be able to intervene. Corticospinal injury is associated with what? So there is a Babinski sign, superficial abdominal reflex is absent, clasp knife rigidity is a sign of pyramidal tract lesion. What is pyramidal tract lesion? What is pyramidal tract, doctor? Corticospinal tract is called pyramidal tract. So whenever you try to move the joint, initially resistance, after that it will give up. Because if you look at flexors and extensors, it is not evenly involved in corticospinal tract. It involves weakness of extensors more than flexors. So that is the reason clasp knife rigidity will occur in pyramidal tract. What are extrapyramidal tract? Rubrospinal, reticulospinal, vestibulospinal, tectospinal. ये सब चीजों को क्या बोलते हैं? Extrapyramidal. In extrapyramidal lesions, there is a involvement of both flexors and extensors equally. So that is the reason there is a resistance throughout the movement of the joint. What is that called? Lead pipe rigidity is what you need to remember. Lead pipe rigidity is a feature of extrapyramidal. Clasp knife rigidity is that of pyramidal tract lesion is what you need to remember. What is the likely affected in aneurysm of PCA, posterior cerebral artery? So you should know that you have the midbrain, from the midbrain nuclega, oculomotor nerve. Oculomotor, trochlear, they arise from third and fourth, they arise from midbrain. So the two vertebral arteries become basilar artery. Basilar artery become posterior cerebral artery. And posterior cerebral artery communicates with the internal carotid artery through posterior communicating artery. Any posterior communicating artery aneurysm will compress the oculomotor nerve, which is coming out of the midbrain. It leads to compression of oculomotor nerve is what you need to remember. So this is how an aneurysm, which is arising from the posterior communicating artery, right, will cause the compression of the oculomotor nerve. So this is how you can see patient presented with oculomotor nerve palsy, and you discovered that there is a posterior communicating artery aneurysm, and you have done the embolization and placed a coil, and that's how you have reduced the aneurysm and relieved the pressure on the oculomotor nerve is what you need to remember. So this is how, doctor, typically there is a pupillary dilation and ptosis because of the oculomotor nerve palsy, right? So what is the reason for that? When the pupil is involved, then the cause is surgical. If there is an oculomotor nerve palsy with normal pupil, then it is a medical causes like diabetes, hypertension, arteriosclerosis. Any of them can lead to development of pupil sparing oculomotor nerve palsy is what you need to remember. So typically you can once more see the optic nerve and chiasma and the oculomotor nerves arising at the level of the midbrain is what you need to remember. So cavernous sinus aneurysm lead to sixth nerve palsy. Posterior cerebral artery and internal cerebral artery aneurysms lead to third cranial nerve palsy. Pain behind the eye is the feature of middle cerebral artery aneurysm. Clinically is what you need to remember. Blink reflex is used for. So typically in the mid-pontine lesions, blink or corneal reflex is lost whenever the lesion is the level of the pons, because corneal reflex ke liye, what are the two important? Afferent is with fifth cranial nerve, trigeminal, right? Trigeminal. Efferent, you will close the eyelid, facial. Both of them are located in the pons. So that is the reason any pontine lesion will make you to lose the corneal reflex, is what you have to emphatically remember. Gait apraxia. Where do you see gait apraxia? Whenever there is any thromboembolic episode involving anterior cerebral artery, very important. So ACA, MCA, PCA, posterior cerebral artery, middle cerebral artery, anterior cerebral artery. So anterior cerebral artery you don't get hemiplegia. Anterior cerebral artery, typically a paramedian lesion like this will be found. This is the area which will control opposite side lower limb is controlled by this paramedian strip of the motor cortex, which is supplied by anterior cerebral artery. That's the reason whenever anterior cerebral artery stroke is there, patient will not have any hemiplegia, quadriplegia. All the drama you see in middle cerebral artery will not be there in anterior cerebral artery. What the anterior cerebral artery occlusion will lead? Patient will have contralateral lower limb monoparesis. Monoparesis is what you need to remember. Contralateral lower limb monoparesis. Patient will be having a shuffling, freezing gait with imbalance, higher cerebral dysfunction, typically in case of gait apraxia, is what you need to remember. So quickly summarize, doctor, each of these territorial strokes, which is the favorite topic of the examiner. Anterior cerebral artery infarction lead to contralateral monoparesis of the leg and foot, cortical sensory loss over the leg and foot, and primitive reflexes are there, no? Like if you happen to like lip smacking and all, Gegenhalten, all these primitive reflexes will come back because anterior cerebral artery controls frontal lobe. So frontal lobe, if it is affected, then that leads to development of disinhibition, and that disinhibition lead to the emergence of the primitive reflexes which we lost in the childhood. That is a very important feature. Similarly, anterior cerebral artery also supplies frontal lobe. Frontal lobe is the highest center for controlling our urinary continence. Suppose suddenly our bladder is full, but we are in a public place, we want to wait until going to the toilet. So who will tell the bladder to not piss? It is the frontal lobe. So once frontal lobe is involved in anterior cerebral artery infarction, there is a urinary incontinence, gait apraxia, mutism, lack of spontaneity of the motor acts, apraxia of the left-sided limbs, whenever the corpus callosum involvement is there. So these 5 points about anterior cerebral artery occlusion you need to remember for the tomorrow's INICET, doctor. Promise me. Contralateral lower limb monoparesis, number 1. Number 2, urinary incontinence. Number 3, gait apraxia. Number 3, mutism, lack of spontaneity of motor act. Number 5, apraxia of the left-sided limbs is what you have to remember. So, doctor, bilateral Babinski is characteristic feature of pontine hemorrhage. Why? Because pons is the center for efferentiation. So the corticospinal tract, which is descending down, bilaterally get affected whenever pons is affected, and that lead to bilateral Babinski is a feature of pontine hemorrhage, is what you need to remember. What will happen if the hemorrhage is there in putamen? Putamen lead to contralateral hemiplegia, speech becomes slurred, arm and leg gradually weaken, eye will deviate away from the side of hemiparesis. So, if the putamen is involved, hemiparesis जिस तरफ होता है उसके opposite side को eye deviation होता है, and there is a lot of drowsiness. It will give rise to stupor whenever the upper brainstem compression occurred with putaminal hemorrhage. Ultimately, putamen, basal ganglia lead to coma. deep, irregular, intermittent respiration whenever the putamen is involved. And there are dilated fixed ipsilateral pupil, bilateral Babinski, decerebrate rigidity, progressive deterioration over the next 12 to 24 hours. So what is this bleed, doctor? This is thalamic hemorrhage. Whenever the distal internal carotid artery occlusion is there, thalamic hemorrhage. So how does thalamic hemorrhage present, doctor? So each of these hemorrhagic presentations, clinical presentation, basal ganglia, thalamus, pons, cerebellum, all these things you should remember, doctor. Thalamic hemorrhage. It also leads to hemiplegia, hemiparesis, prominent sensory deficit. Wherever thalamic hemorrhage is there, entire half of the body sensory deficit. Aphasia. What kind of aphasia? Verbal repetition is preserved. Whenever the dominant left thalamus is involved, there is a aphasia where repetition is preserved. Epractagnosia or mutism, whenever non-dominant thalamus is involved. And there is a transient homonymous visual field defect whenever the thalamic bleed is there. And there is a deviation of the eyes downward, inward, like convergence. I told you, hyperconvergence is a feature of thalamic bleed. Unequal pupils. And thalamus is the area where your sympathetic system is originating from hypothalamus and descending down. So that is the reason there will be Horner syndrome. And all these other features. Similarly, there's a paralysis of vertical gauge, retraction nystagmus. They're all the features of thalamic bleed. So what you can see is a huge pontine hemorrhage. This pons is then a pons. Pons is the center for efferentiation, entire motor output going to the upper limbs, lower limbs, everything, corticospinal tract, invariably pass to the pons. Hence, pons is called center for efferentiation. Thalamus is called center for afferentiation, is what you need to remember. So what is this? A huge pontine bleed. Pontine bleed is what you are able to see here. So whenever pontine hemorrhage is there, pinpoint pupils is the characteristic feature. Pinpoint pupils, hyperthermia, hyperventilation. These are the features of pontine hemorrhage. And hemorrhage may contralateral side, there will be hyperhidrosis, contralateral hyperhidrosis. Often, it is the hypertensive bleeds or pontine bleeds. There is a disruption of the contralateral inhibitory sweating pathway. That's the reason pura pasina aata hai. But only one side, contralateral hyperhidrosis. 1/3 will have severe headache. Vomiting is seen in about 20% of patients. Seizures, mostly flexor spasms, are reported in 30% of patients, is what you need to remember. So, quickly summarize all the pontine hemorrhage features, doctor. Deep coma with quadriplegia. Because pons is the center for differentiation. Impairment of the horizontal eye movements. That's called Doll's eye reflex, oculocephalic maneuver. When you move the head, no. When you move to right side, your eyes will move to left side. When you move to left side, your eyes will move to right side. But here, if you move the head to right side, the eye also move to right side only, instead of opposite side. Then hyperapnea is the feature of pontine bleed. Hyperhidrosis, death usually occurs within few hours. Pontine, right? And is very, very important to remember. Can the online students can punch? Is the voice loud and clear for all of you, doctor? A patient has a native aortic valve disease, comes with right hemiparesis. What will you do to prevent further stroke? So fundamentally, it is the aspirin, doctor. Aspirin, clopidogrel, they're all wonder drugs. We think We think they are not that important. After all, aspirin tablet, but the main decision of a cardiologist, neurologist is aspirin or no aspirin. That's the reason aspirin, clopidogrel, very, very important. 50-year-old male comes to emergency with right hemiparesis, BP is high. What is the next step? Always, whenever ischemic stroke or hemorrhagic stroke, you need to first confirm before you start thrombolytic. So, first thing to do is non-contrast CT. There's a vascular lesion in the mid brainstem in this area which is being depicted. What will this cause? So fundamentally, this is the lateral part of medulla, lateral medullary syndrome of Wellenberg. Wellenberg is what you need to remember. So in the lateral part of the medulla, what are all the things that are located and what does it, and their involvement? What are the symptoms, doctor? Vestibular nuclei, vomiting, vertigo, nystagmus will be there. All our balance gone, lateral medullary syndrome. Inferior cerebellar peduncle that is connecting the medulla with the cerebellum. There is an ataxia, dysmetria, dysdiadochokinesia, all the ipsilateral cerebellar signs. Similarly, central tegmental tract. Tell me what is that called? Central tegmental tract. Because of that, palate will be showing myoclonus, palatal myoclonus. Lateral spinothalamic tract is involved, and that lead to contralateral deficit in pain and temperature of the body. Spinal trigeminal tract is bringing all the pain, touch, kiss, everything from ipsilateral cheek. So there's ipsilateral loss of pain and temperature sensation from the face. Ipsilateral. But lateral spinothalamic tract is bringing pain, temperature from the contralateral side of the body. Spinal trigeminal tract from the ipsilateral part of the face. Don't confuse that. Nucleus ambiguous is also there in the lateral part of the medulla. It will affect the vagus nerve, glossopharyngeal nerve, and that lead to ipsilateral, laryngeal, pharyngeal, palatal, hemiparesis leading to dysphagia, hoarseness, diminished gag reflex. Then descending sympathetic fibers are affected. That's the reason. Ipsilateral Horner syndrome, ptosis, meiosis, anhydrosis. They're all the features of lateral medullary syndrome is what you need to remember. Very good to see. Sanjana Patak, Meghaswana, Alladi Vinay, Mithuna, everybody, thanks for attending the session. As I told you, with students 3 घंटे, without students 1 घंटा, right? So कम से कम 1-2 घंटे तो मिलना पड़ेगा रोज, नहीं तो मजा नहीं है, हमको भी नींद नहीं आएगा, आपको भी नींद नहीं आएगा. So doctor, which is not a diagnostic criteria to declare the brain death. To declare the brain death. A positive apnea test, brainstem reflex absence, loss of cerebromotor response, even if you pinch, cut the limb also. So these are all the features to declare brain death. So what are the clinical criteria before you call brain death? Is the favorite MCQ in the INICET. Number 1, loss of consciousness, absent motor response, absent brainstem reflex, apnea, acute CNS catastrophe, absent electrolyte or acid balance. Always. Is there any hyponatremia? Check it before you call brain death. So electrolyte disturbances, acid-base imbalances also can lead to picture similar to brain death. Very commonly, doctor, I can never forget, barbiturate poisoning. You should rule out. Send the serum for toxicology sample before you declare brain death. Otherwise, patient will wake up from the graveyard and come to your home. Now, a patient presents with brainstem hemorrhage given in the picture. What are all the features do you expect? Except. So, typically you need to know that contralateral loss of touch and pain, severe visual dysfunction, they're all possible Bladder dysfunction is a problem whenever the frontal lobe is involved in anterior cerebral artery stroke, not in the brainstem stroke. Simple. So that completes short topic cerebrovascular accident. So in the notes I gave to you, 1200 pages notes. Doctor, please don't forget 1200 pages notes. 50,000 high-yield facts. Garma garam. Today only you order it and we will courier you the notes, doctor. Courier the notes to your home. If you read this 50,000 high-yield facts, master kare to automatically you will get the top rank. Please download Score Learning app. In that you have 600 hours of video. That is short videos. 10,000 videos which discussed these 50,000 high-yield facts that are given in the physical notes. That is more than enough for you to win the entrance exam. So some of you may be new to our live broadcast. Every day we have a absolutely free live broadcast, doctor. Free कुछ भी नहीं है जिंदगी में. हमारा मकसद है आप ये देखने के बाद हमारा स्कोर ऐप डाउनलोड करके 1200 पेजेस नोट्स खरीदोगे. Small subscription fee, 999 rupees for 1 month, 30 days. You have everything, notes in the app, video library, mock tests. Now tonight we are introducing audio mantras tonight or tomorrow night. There are about 10,000 audio mantras for you to do quick revision. You have a point question, think about what is the answer, and you have a audio to give you the explanation. फटाफट revision कर सकते हो, last moment चटपटा points in the form of audio mantras. Okay, doc? So let's do the revision. The next topic of the examiner is epilepsy. What are the features of juvenile myoclonic epilepsy? Juvenile myoclonic epilepsy. Typically, patient will have myoclonus after waking up from the sleep. Typically, the kid will be walking to the table to do breakfast. Mama serves nice breakfast. So the kid is about to eat the food. Suddenly he will have a myoclonic jerk. That's called salam spell. जैसे salam बोलो बेटा बोले तो ऐसा आदाब करते ना ऐसा. They are called salam spells, myoclonic epilepsy. Similarly, automatisms, absent seizures. Automatisms are not seen. Absent seizures, generalized tonic-clonic seizures, myoclonus on awakening. Automatism is a feature of complex partial seizure, not juvenile myoclonic epilepsy. So what are automatisms? Involuntary automatic behavior having a wide range of manifestations like chewing, lip smacking, swallowing, or picking movements of the hands, or more elaborate behavior like display of emotion, sudden running. They're all automatisms. Automatisms are a feature of complex partial seizures, not juvenile myoclonic epilepsy is what you need to remember. Very good to see 14 online classmates. So, doctor, myoclonic seizures are most frequent in the morning after you awaken, and they are provoked by sleep deprivation. Consciousness is usually preserved in the seizures and it is not lost. So these are the typical EEG finding in myoclonic jerks, where you find 4 to 6 second irregular spikes. You'll remember this, no? Tomorrow, NEET PG, INICET examiner will give you this 4 to 6 per second irregular spikes, and you need to identify myoclonic jerks. Treatment क्या होता है? Valproate. Lifelong treatment is required with valproate. Juvenile myoclonic epilepsy, drug of choice, you need to remember, doctor. Drug of choice. So, these are all the drugs used to manage the status epilepticus. Phenytoin, diazepam, thiopentone, sodium, they're all used for status epilepticus. So now, doctor, this is one favorite question of the examiner. How do you manage status epilepticus? First 30 minutes, early status epilepticus. Give benzodiazepines like IV lorazepam, buccal midazolam, rectal diazepam. Stage 2 is 30 to 120 minutes. Established status. Give phenytoin, phenobarbital, valproate. Stage 3, more than 2 hours beat gaya. It's called refractory status epilepticus. You need to give general anesthesia. Air Force, Army, kuch bhi nahi kar sakta. Air Force now. Propofol, midazolam, thiopentol, phenobarbital. After 24 hours, it's called super refractory epilepticus. Despite general anesthesia for 24 hours or more, if the seizures are continuing, you call as super refractory status epilepticus. Now, how do you manage status epilepticus? What are the drugs? What are the dosages? Favorite question. Lorazepam, 0.1 mg per kg, IV at 2 mg per minute. Like a parrot, you have to rattle out this dosage, doctor. Phenytoin, fosphenytoin, 20 mg per kg, IV at 50 mg per minute, fosphenytoin, 20 mg per kg at 150 mg per minute. Then additional 5 mg per kg, phenytoin or fosphenytoin. If it is not resolving, then phenobarbital, 20 mg per kg, IV at 50 mg per minute. And then additional 5 to 10 mg per kg phenobarbital. If phenytoin से control नहीं हो रहे तो phenobarbital दे सकते, नहीं तो anesthesia with midazolam or propofol is administered, is what you need to remember. These are all the features of absent seizures, except absent seizures are seen in childhood, 3 Hz spike wave, precipitation by hyperventilation, no postictal confusion. So what is this, doctor? The child will be looking through the teacher instead of at the teacher. Child will be looking through the teacher rather than at the teacher. That is the description of absent seizures. So this is how a man watching the TV suddenly will have absent spells. So a lot of times the child will be taught as inattentive child by the teacher because suddenly attention dena band karke vacant stare de raha hai. It's called inattentiveness. So typically absent seizures, there's a pause in activity, blank stare, brief lapse of awareness, chewing, blinking motion. It lasts 1 to 10 seconds. Sometimes it can occur many times a day. That's called pycnolepsy. Pycnolepsy is the status of absent seizures. And what is the common confusion of absent seizures differentials? Daydreaming, lack of attention, attention deficit activity disorder बोल के अगर आप सोच रहे हैं तो वो सही नहीं हो सकता, वो absent seizures हो सकता है. So what is the first line treatment, doctor? So very nice to see 15 online classmates. So today I could not go to the learning center. I thought at least ek ghanta padhenge milke. So every day at least 3 to 4 hours we should spend time together to discuss the PYQs, doctor. 8,800 PYQs in total, 44 exams. 2,000 aims to 2022 INICET को. Totally 8,800 क्वेश्चन बैंक को खेलते खेलते रिविजन करेंगे. Top 20 topics in every subject of the examiner. 20 into 19 subjects. 380. Large subjects में 40 ले लो, पकड़ लो. तो पूरा 500 high yield topics हम रिवीजन करेंगे खेलते खेलते। लास्ट मोमेंट में आप ये 500 टॉपिक्स को गर्मा गर्म रिवीजन करना, बस you will be in the top 100 ranks miraculously. All right, so please be part of the live sessions, doctor, because recorded video is a piece of shit. Even the world's greatest teacher comes and teach also, attention nahi rehta. We're all ADHD kids. We don't want to stay too long. We don't give damn care if the lecture is more than 20 minutes in video. That's the reason. So, doctor, let's talk about absent seizures. Valproate, ethosuximide, first line. Lamotrigine, clonazepam, second line. EEG, 3 hertz, spike and wave, don't forget. Hyperventilation will try to provoke the absent seizures. Which drugs are used to treat status epilepticus, which is the favorite topic of examiner? Phenytoin, diazepam, thiopentone. Early status, established status, refractory status, super refractory status. Thiopentol, propofol, midazolam, refractory status. Lorazepam, clonazepam, diazepam, early status. Phenytoin, phenobarbital, established status. Please don't forget. So what is the drug of choice, doctor, for the absent seizures? Valproate. So all these first line drugs, doctor, you have to be very, very sure. Valproate, lamotrigine, primary GTCS, primary GTCS. Then partial seizures including complex partial, simple partial, secondary generalized. Secondary generalized means पहला वो फोकल पार्शियल के जैसे शुरू हुआ, बाद में जनरलाइज हुआ, सो इसको बोलते हैं सेकेंडरी जनरलाइज। वहां भी क्या इस्तेमाल करते हैं? यू ट्रीट इट लाइक पार्शियल सीजर, कार्बामेज़ेपिन, फिनेटोइन, लामोट्रिजिन, वाल्प्रोएट। Absent seizures, valproate, ethosuximide. Atypical absences, myoclonic, atonic, all that, it is the valproate is what you need to remember. Very good. Make us wanna keep punching. जो भी points आपको याद आता ना, keep punching. First drug to be used in absent seizure. First drug to be used in absent seizure. Valproate. 75-year-old man, new onset focal seizures, normal renal function. What is the preferred drug? Oxcarbazepine. So these are all second generation, doctor. Felbomate, gabapentin, lamotrigine, levetiracetam, oxcarbazepine, then topiramate, zonisamide, all these things. And you need to be careful. Two, three points about each of them. Already in pharmacology, doctor, हमने दिल खोल के पूरा डिस्कस करके 1200 पेजेस नोट्स में भी दिया आपको. Please revise anti-epileptics. One question, shoot shot in the tomorrow's INICET exam. A 4-month pregnant lady treated with the valproate regularly. She asks your advice. Can I become pregnant, doctor? What is your course? Continue valproate, but monitor the blood levels is what you need to remember. So anti-epileptic drug therapy should be optimized even before conception. In case of valproate, high plasma levels should be avoided unless necessary to control seizures. And it need to be given in divided doses 3 to 4 times. And this patient has juvenile myoclonic seizures. And the drug of choice is valproate. If the patient with juvenile myoclonic seizure is planning pregnancy, she need to switch to lamotrigine from valproate is what you need to remember. But patient is already 3-month pregnant. The damage to the fetus cannot be prevented. The most common clinical presentation of juvenile myoclonic epilepsy, क्या होता है? Obviously myoclonus होता है. Intractable seizures, which modality of treatment has shown best seizure-free interval? Intractable seizures are often because of what, Dr.? Medial temporal lobe sclerosis is what you need to remember. It's called mesial temporal lobe sclerosis, MTLS. So for that, the only way is that temporal lobe, which is sclerotic, need to be removed. Resective surgery need to be done. Even vagal nerve stimulation, deep brain stimulation, ketogenic dietary therapy, they're all considered to be options for refractory seizures. Which drug is effective for monotherapy as a replacement for sodium valproate in a female who is having juvenile myoclonic epilepsy? So many times asked. May 2013, November 2013, आप levetiracetam. You need to remember, doctor. As a replacement of valproate in juvenile myoclonic epilepsy who want to become pregnant. How do you differentiate seizure from syncope? Seizure from syncope. Whenever there is a physical weakness with a clear sensorium. So please remember, seizure versus syncope, जो शास्त्रीय वाद विवाद है, वो जरूर पूछेगा. Examiner expects you to know that. More than 50% of seizures have aura. They will feel déjà vu, jamais vu, smelling of the burning of the tides, etc. But syncope mein, the premonitory symptoms are they feel faint, lightheaded, blurred, darkened vision. Onset seizure can be sudden in any position. आप शीर्षासन डालो, योगासन डालो, कोई भी आसन डालो, शुनकासन डालो, वामनावतार ले लो, seizure आएगा. Syncope only occurs sitting or standing, and it is avoidable by changing the posture. In seizures, eyes are open, rigidity falls backwards and convulses. Syncope occurs only standing or sitting, eyes closed. Seizure वाला आदमी eyes closed करेगा. I mean syncope वाला. He falls forward, not backward. Seizure वाला backward. Minor twitching only will be there in syncope. On recovery, seizure patient will be confused, headache, sleepy, focal deficit, like thoughts palsy. Whereas syncope may he'll be pale, washed out, sweating, cold and clammy. Seizure may there is a tongue bite, loss of bladder control. Whereas loss of bladder control, passing urine into the lungi is not the feature of syncope, is what you need to remember. Now, doctor, recently approved drug for the treatment of Lennox-Gastaut syndrome is rufinamide, is what you need to remember. So what is Lennox-Gastaut syndrome? Kabhi suna kya? Lennox-Gastaut. Tonic seizures, atypical absences, tonic-atonic drop attacks, non-convulsive status epilepticus. Non-convulsive status epilepticus means कुछ भी मोटर एक्टिविटी नहीं रहता, ऐसा बैठ के टीवी देखते रहता, उसके अंदर सीजर्स चलते रहता. दैट्स कॉल्ड नॉन कन्वल्सिव स्टेटस एपिलेप्टिकस. लेनॉक्स-गास्टाट में इंटरइक्टली slow spike waves and paroxysmal fast rhythms, non-REM sleep. They have cognitive impairment with intellectual slowing and behavioral problems. Rufinamide, kya hai amide? Rufinamide, rufinamide, rufinamide. Rufinamide is approved for the treatment of Lennox-Gastaut in the children 4 years and older, and in adults is what you need to remember. So, doctor, with this, we'll take 2 more topics before we say goodbye, because almost 17 students are online. हम बहुत खुश हैं. हमने 1 घंटा पढ़ाने के लिए सोचा, मगर आप 17 लोग आ गए, मैं कैसे बंद करूंगा? 2 more topics, 2 more topics, please. 45-year-old hypertensive, sudden onset of severe headache, vomiting, neck stiffness, no focal neurological deficit. Always this is important. CT show blood in the sylvian fissure. ये सब बोलने के बाद भी भैया आप Subarachnoid hemorrhage because of a ruptured aneurysm नहीं बोले तो मुरली भरद्वाज का स्टूडेंट कैसे बनोगे? भैया ये होता है, सिल्वियन फिशर होता है. सिल्वियन फिशर के अंदर नॉर्मली ब्लीडिंग या ओपेसिटी नहीं रहता है. अगर हो गया तो सोचना subarachnoid hemorrhage is what you need to remember. So whenever aneurysm ruptures, the blood will spurt, and that spurting blood can cause focal vasospasm, and that surrounding blood around the blood vessel, vasospasm, then focal neurological deficits will occur. Focal neurological deficit means hemiplegia and all that. Normally, subarachnoid bleed kahan hai? Subarachnoid hemorrhage is outside the brain parenchyma. Generally, it does not lead to any hemiplegia like focal neurological deficits unless the bleed which is surrounding the blood vessel lead to intense vasospasm, lead to hypoxia to the part of the brain supplied by that vessel, then it will occur. That's the reason what is the most important object of the subarachnoid hemorrhage, doctor? Hydration. 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 Hydrate the patient. Nimodipine, 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 sister, nimodipine. Because nimodipine is a vasodilator. It prevents focal spasm of the vessel because of the surrounding subarachnoid hemorrhage. Hyperventilate the patient if required. Do whatever, but patient should not develop focal neurological deficits. So this is how the subarachnoid hemorrhage look like. You need to do the clipping of that aneurysm which is undergone rupture. So these white colored areas are typically pooling of the blood in the sylvian fissure. Sylvian fissure in the subarachnoid space. So this is how the whole brain spattered with the blood in the subarachnoid space, not inside the brain, overlying paya or arachnoid ke beech mein, and all the blood will percolate through the gyri and sulci, through sulci. That's the reason sylvian fissure will show the presence of the bleeding is what you need to remember. So this is how typically you see subarachnoid hemorrhage. This is that aneurysm. Can you see this, doctor? Can you see this? Yes, sir. This berry aneurysm is the one which has undergone the bleeding is what you need to remember. 45-year-old hypertensive presented to casualty, severe headache, thunderclap headache. I never had this much a bad headache. He has a neck stiffness because it is subarachnoid bleed. Right-sided ptosis. Rest of the examination is normal. So the hallmark of any aneurysmal rupture is the bleeding into CSF. Right-sided ptosis in this patient is because of the third cranial nerve palsy by that aneurysm which has causing subarachnoid hemorrhage. Posterior communicating artery aneurysm has undergone bleeding. Compression, that is causing compression of third cranial nerve. The most common cause of subarachnoid hemorrhage is aneurysm. Aneurysm, saccular aneurysm, severe headache, neck stiffness, abrupt onset, nauseated, photophobia. You need to think about subarachnoid hemorrhage. So many times, most repeated topic in entrance exam is subarachnoid hemorrhage. One subdural hemorrhage, epidural hemorrhage, cerebrovascular accident के बारे में एटलीस्ट 2 प्रश्न पूछा जाएगा. VVVVIP topics, VVVVIMP topics. Patient has a thunderclap headache, unconsciousness, third cranial nerve palsy. You need to think about aneurysmal subarachnoid hemorrhage. So what is this called? Thunderclap headache is what you need to remember. So what do you mean by thunderclap? At the onset, there will be maximum intensity. Oh, what a pain in my head. Like a clap of thunder is the classical feature. So what are the danger signals whenever any patient comes with headache, doctor? If he says, doctor, I had a sudden onset of this headache, which is thunderclap. Worst headache, जिंदगी में मुझे कभी भी इतना headache नहीं आया. जब मैं शादी किया भी नहीं आया. जब सुहाग रात भी इतना वर्स्ट हेडेक नहीं आया. अगर पेशेंट बोले तो सोच लो subarachnoid hemorrhage. Headache dramatically different from past headaches. If the patient has an immunocompromised and have headache, means think about cryptococcal meningitis, very severe headache. I still remember Rajaya was my HIV patient, crying in the ward, rolling, doctor, मुझे मार दो, एक चाकू लेके मार दो doctor, ये headache मेरे पास में नहीं होता. So he had cryptococcal meningitis. Rajaya was my patient. I still remember him crying, rolling in the ward floor. Headache that begins with exertion, typically while having sex, coitus, subarachnoid hemorrhage, mar gaya. So that is a intracoital death or straining at the time of stool that lead to sudden rupture leading to headache. Similarly, altered mental status, meningeal signs, focal neurological signs, any spotted fever, rash with headache, meningitis. So all these things you need to remember. So neck stiffness with headache means always be careful, doctor. You need to evaluate for the possibility of subarachnoid hemorrhage is what you need to remember. SK says door to needle time is 90 minutes, sir. Because door to CT time is 20 minutes, CT interpretation time is 45 minutes, so door to needle time never be 30 minutes. Very good. Good SK. So Ganesh is saying, sir, take daily 5 hours of class. आप हैदराबाद आओ, गणेश, मैं सचमुच बोल रहा हूँ, तो हैदराबाद आओ, चाय पियेंगे, समोसा खाएंगे, 5 घंटे क्या 10 घंटे बैठ के पढ़ेंगे. बट ऐसे कंप्यूटर को आप गंगा नदी के उस पार पे मैं और इस पार पे बैठ के पढ़ाई कर रहे तो 1 घंटे पढ़ाई देने से ही सबरकनाइड ब्लीड हो जाएगा. So that's the reason, very difficult, doctor. We think that online students, online teachers, easy job. No, offline is very easy to teach. क्योंकि स्टूडेंट्स रहता मजे में पढ़ाई दे सकते हैं. ऑनलाइन में पूरा क्या है, कंप्यूटर को देखते हुए बोलना. So doctor, thunderclap headache, don't forget. Patient presented with thunderclap headache, unconsciousness, progressive cranial nerve third palsy, aneurysmal subarachnoid. Berry aneurysm, that is why does berry aneurysm occur? Because it is the media. The media will undergo mucoid degeneration. Berry aneurysm. Mucoid degeneration of the media lead to berry aneurysm. So 3 types of aneurysm, doctor: saccular or berry aneurysm, which is the most common type of aneurysm. Most of them are in neck area. Rupture is very common. Second is called fusiform aneurysm, where fusiform bole to nest ke jaise, fusiform. It has expanded in all directions, commonly due to atherosclerosis, don't involve the neck, and rupture is uncommon. Third is mycotic aneurysm or infectious aneurysm, which arise from arteries. The most common complication associated with brain aneurysm is what? Rupture is what you need to remember. Now, an adult hypertensive, sudden onset, severe headache and vomiting, marked neck rigidity, no focal neurological deficit. What are due to? Subarachnoid hemorrhage. Once more, AIMS November 2013 May. Sudden severe headache 2 hours ago, unconscious upon regaining consciousness, photophobia, neck rigidity. You need to do non-contrast CT scan. Elderly hypertensive presented with sudden onset headache, vomiting, neck rigidity without focal neurological deficits. Subarachnoid hemorrhage is what you need to understand. The last topic for the today's evening, doctor, meningitis. Meningitis. So tell me, what is the order in which you will revise neurology for tomorrow's INICET exam? पहला सीधा बुक में जाके cerebrovascular accident, MCS stroke, ACS stroke, PCS stroke, every lenticulostriate, lacunar infarcts, thalamic bleeds, basal ganglia bleed, pontine hemorrhage, everything revision kar. Barabar. Then Next, what will you do? Subarachnoid hemorrhage. Epilepsy. Very important topics, doctor. Sure shot आएगा. Even meningitis also. क्योंकि pediatrics में meningitis होता है, adult medicine में होता है, microbiology में होता है, सारे जगह पे होता है. What are the neurological complications of meningitis, doctor? Subdural effusions, increased intracranial pressure, seizures, anything can occur. Hydrocephalus, cranial nerve involvement, subdural effusions, subdural empyema, pus collection under dura, cerebral herniation, cranial nerve involvement, anything can occur. What are the most common causes of sporadic viral encephalitis? It is the herpes simplex encephalitis. Herpes simplex encephalitis. Remember, favorite questions, 3 questions. Most common cause of sporadic viral encephalitis, HSV1. Most common cause of epidemics of viral encephalitis, arboviruses. Most common cause of viral meningitis or aseptic meningitis, enterovirus. Like a parrot. You need to repeat in the tomorrow's exam. 6-year-old man with complaints of progressive dementia. Past 6 months, intermittent jerky movements. EEG shows sharp bipolar spikes. Sharp bipolar spikes. Dementia, na? So Creutzfeldt-Jacobs disease. So what are these called? Periodic. What are these called, doctor? They are called periodic sharp wave complexes on EEG is a very characteristic feature. Periodic sharp wave complexes on EEG, repeated at an interval of 1 to 2 seconds. Once more, periodic lateralized epileptiform discharges is the feature of Creutzfeldt-Jacobs disease. 25-year-old, 1 month duration of fever, dilated ventricles, basal exudates, basal. TB. So lymphocytes, low glucose, high protein. Lymphocytes, this is called basal exudates. That's the reason TBMA, you need to give steroid in order to prevent these exudates. If they are there, then that can lead to cranial nerve palsies like hearing loss, everything can occur. Significant basal exudates with dilated ventricles, hydrocephalus in a young female who has fever, headache, suggest tubercular meningitis. So what do you have in tubercular meningitis? Lymphocytic pleocytosis, low glucose, hypoglycorrhea, you need to remember, and high proteins. So relative sparing of the convexity of the brain and predominant involvement of the basal meninges, characteristic pathological feature of TB is what you need to remember. It will obliterate the pontine system, interpedunculae system, which is encasing the cranial nerves, is what you have to remember. Elderly male presents with headache, fever, hemiparesis on right side. Brain abscess is your diagnosis. What are the drugs you want to give? Cephalosporin, metronidazole. Cephalosporin, metronidazole is the best combination. So what do you see here? Headache, fever, hemiparesis with brain abscess. So in brain abscess, penicillin G covers most of the mouth flora, including aerobic and anaerobic streptococci. Metronidazole penetrates brain abscess, intralesional concentrates are achieved. It has an excellent bactericidal property against many anaerobes, but it is not active on aerobic organisms or microaerophilic streptococci. So ceftriaxone, it covers aerobic, microaerophilic streptococci, but many enterobacteriaceae also. So this is ceftazidime. Ceftazidime, cefepime, meropenem, they should be used in brain abscess, which is complicated by neurosurgical procedures. Or whenever abscess culture is growing, Pseudomonas aeruginosa, ceftazidime, cefepime, meropenem. Anti-pseudomonal drugs are ceftazidime, cefepime, meropenem is what you need to remember. Then this is oxacillin. Oxacillin, nafcillin, vancomycin, they're all good for the Staph aureus bacteremia. If you documented any penetrating head trauma or craniotomy, then oxacillin, nafcillin, and vanco need to be remembered. So this is vanco. It is particularly needed for post-neurosurgery patients in hospital-associated infections. Whenever MRSA is suspected, vanco. And remember, what are the antibiotics useless for meningitis? Because they do not cross the blood-brain barrier. Aminoglycosides, erythromycin, tetracycline, clindamycin, first generation cephalosporins, they cannot cross. And generally, what is the empiric antibiotic in brain abscess before you get the results? If it is an immunocompetent patient, then third or fourth generation cephalosporin, cefotaxime, ceftriaxone, cefepime, and metronidazole. If there is a penetrating head trauma or recent neurosurgical procedure, ceftazidime to enhance the pseudomonas coverage and vancomycin to cover the MRSA is the combination. So you should know this prescription thoroughly, doctor. Sure, short question aayega kal ke NEET PG mein. A 45-year-old female is diagnosed to be pneumococcal meningitis. Her blood culture was sent. In the meantime, what is the best drug for empirical treatment? Always ceftriaxone. Ceftriaxone. Patient with tubercular meningitis taking ATT regularly at the end of 1 month of regular intake of the drugs, there is a sensorium deteriorated. So what investigation is required? MRI, NCCT and LFT. Emergency में CSF का जरूरत नहीं है. MRI, NCCT and liver function test. So deterioration of the sensorium in a patient of tubercular meningitis means hydrocephalus. Hydrocephalus will present with increasing headache with or without blurring of the vision. And what are the most common complications of meningitis that can lead to altered sensorium, doctor? Altered sensorium, meningitis के वजह से syndrome of inappropriate ADH secretion can cause hyponatremia. Meningitis can become hydrocephalus like TB meningitis, and that can lead to altered sensorium. Meningitis can predispose to stroke, cranial nerve palsies, etc., etc. A boy has history of fever, headache, vomiting, disorientation, neck rigidity, one episode of GTCS, then became unconscious, CCT normal, and what do you see? Polymorphonuclear leukocytosis. Protein 70 elevated, sugar 50 decreased. What is the most likely diagnosis? Always hypoglycorrhea. That is decrease in glucose in CSF, means think of pyogenic meningitis and even TB meningitis. But TB meningitis mein lymphocytic predominance will be there. That is a differentiator. So will you remember this, doctor? One question sure short. One question sure short. Normally there are no PMNs. Bacterial meningitis 100 to 10,000. Viral is less than 100. Mononuclear cells less than 5. Normally less than 100 bacterial, 10 to 1000 viral. Protein less than 40, less than 0.4. More than 1 is bacterial, 0.4 to 1 is viral. Glucose less than 2.5 millimoles and usually decreased in bacterial but normal in viral. Glucose in CSF to blood ratio less than 0.4 in bacterial meningitis is what you need to remember, doctor. Good, Megaswara. I'm so happy. Keep punching answers, doctor. Be proactive. A patient with tubercular meningitis is taking ATT regularly. At the end of 1 month, regular intake of drugs, deterioration of the sensorium is noted. So what investigation is not required? You don't do CSF, is not required. Lumbar puncture is contraindicated if there is an increased ICT. 32-year-old Bengali woman has fever since 48 hours, irrelevant talk, 2 episodes of tonic-clonic seizures. She was previously all right. What can be given while rest of the investigation is being carried out? So this looks more in this Bengali lady that she developed a herpes encephalitis, IV acyclovir. Typically, herpes encephalitis involves temporal lobe. Temporal lobe hemorrhagic necrosis is the characteristic feature of. You can see this is the temporal lobe. Normal one, this is the infected with herpes encephalitis. Please don't forget, doctor. And this lead to sudden onset of altered sensorium, irrelevant speech. The patient will be telling. So how do you treat, doctor, herpes encephalitis? Intravenous acyclovir, 20 mg per kg TDS for at least 21 days. Birth to 3 months. More than 3 months, intravenous acyclovir. One of the drugs is used in acute bacterial meningitis, ceftriaxone. So always remember empiric treatment. 0 to 2 months, 2 months to 5 years, more than 5 years. 0 to 2 months, what is the etiology? E. coli, gram-negative bacillus, streptococcus pneumoniae, ampicillin or penicillin plus aminoglycoside. 2 months to 5 years, H. influenza, streptococcus pneumoniae, Neisseria, benzyl penicillin and ceftriaxone. More than 5 years, streptococcus pneumoniae and Neisseria, penicillin G is given. So these are all standard questions, doctor, STD questions. Like a parrot, you should answer in tomorrow's exam. No amount of yelling and yawning can change Prince Charles. Be sure. So emergency में IV therapy, third generation cephalosporin, ampicillin, vancomycin, dexamethasone. So once more I leave to you pathogen specific acute meningitis. Streptococcus pneumoniae, vanco plus ceftriaxone or cefotaxime. Neisseria, ceftriaxone or cefotaxime. Listeria, ampicillin or penicillin G plus or minus aminoglycoside. H. influenza, ceftriaxone, ceftaxime. Methicillin resistant staph, vanco plus or minus rifampicin. Enterococcus में vancomycin resistant है तो linezolid, ampicillin resistant है तो vanco plus or minus rifampicin, ampicillin sensitive है तो ampigenta. E. coli, ceftriaxone, cefotaxime, pseudomonas, ceftazidime, cefepime, plus or minus aminoglycosides. I leave all this literature. Even in the notes I have given all this, but still a PowerPoint भी आपको score app में मिल जाएगा and मजे में revision करना. So thank you so much, doctor, for attending the session. Oh my God, 1.5 hours without students, I'm able to deliver a class. With students, पूरा दिन बैठ के discuss कर सकते. Please come to the class. We have a beautiful 200-seater classroom near RTC Crossroads metro station. निकलते ही हमारा learning center है. आप हैदराबाद है तो आओ, मेरा guest बनो और मजे में पढ़ेंगे हम सब मिलके. And be part of our WhatsApp study group. We will update you, intimate you about the upcoming class. Thank you and see you all tomorrow.